Thank you, Riyam. And even though Muhammad reminded me to record, but still, mashallah. Okay, so we're still reviewing what we covered last time. So understanding variation, we said, is looking at data. For the example of the discharge, what did we say? What we will look at? What data?
Structure, process, and outcome measures we are monitoring.
No, what is specific? So I'm giving you now a specific example. Discharge, for example. What
Waiting
data would you look at to understand the variation? This should be easy. We do this all the time in the hospital.
Length of stay of the patients.
You look at the length of stay, yes. What else?
Discharge from the order placed to the patient moving out of the unit.
Yes, so at the time between
Medication.
the order placing till the patient is actually discharged. Somebody
And patient feedback and medication dispense.
Okay, patient feedback and medication. Medication dispensation is gonna affect how soon the patient left. What else?
Patient satisfaction in relation to discharge process.
Patient satisfaction, yes, that was said. And we actually have in the breast gain survey multiple questions that addresses only the patient satisfaction. And then
you are meaning the pre-admission review, those things, like you are saying concurrent review and retrospective review. Utilization management you are talking when you are saying about variances.
Utilization. So discharge is one element of your utilization management, yes. But for example, in the currently we look at because we aim to discharge patient early, we look at a measure called discharge before 12 noon. It's one of the KPIs for the hospital.
Yeah.
So all of those things, you look at every possible KPI or data points that's talking about the discharge, and then you look at it. And then you select a potential process to improve. Now, from the bigger process of discharge, what could be a smaller process that you can focus on?
You will select where is the variation from this, whatever you have reviewed.
So what could be examples?
Maybe discharge before 12.
So discharge before 12 is an issue that we're looking at. But discharge before 12, okay, let's talk about discharge before 12. It's affected by what?
Like by medication. If the medication is delayed, then we will specifically.
Yeah, and physician may be putting the discharge paper late.
Yes. So you gave me now two processes. Excellent. You said the medication dispensing might be an issue, and you say the physician discharge orders and discharge prescription might be the issue. So you select based on the data, based on the numbers, you look at any process that looks like it's the most, sometimes they call them the bottleneck, sometimes the most delaying process, and then you try to improve that. So if it's about discharge summary being ready, activities like making sure the patients who are eligible for discharge are looked at before. So then you start working on your plan, do, check, act. If it is discharge summary, then you're gonna work with the physicians, make sure the patients are identified beforehand. The discharge summary is drafted and updated on a regular basis to the patient's. So all of this is just to come on to that specific point. That's when we use the focus. We want to come, instead of trying to work on everything that's discharge, we want to just work on one element of it that's really impacting the overall process. Make sense?
Yes.
Okay, so focus is a way to narrow the number of activities of processes that you would like to apply the BDCA to. Okay. PTAC, we said it's plan, test, act, and then check effectiveness. It's like the BDCA, but it only focuses on the pilot activities. The Xerox we talked about, it's one of the benchmark practices that you do, where you try to find some of the best companies or the comparative companies, and then you compare your performance with their performance. Okay. I don't think this is where we reached last time, I believe. So now we'll start with the lean management. We're going to continue with the different quality management approaches. So for the lean approach, lean increases customer value by eliminating waste throughout the value stream. Okay. What is the value stream? If I say, again, I'm going to take it into an example. If we continue to talk about the discharge process, what is the value stream of the discharge process?
Discharging early is the value, as earliest.
The value stream, though, is what?
Getting beds free for admission to expedite the admission.
Yeah,
maybe reduce time in ED.
There's a difference between value and value stream.
Okay.
The value, yes, the value is we're trying to improve admissions from ED, we're trying to free up more beds, we're trying to increase utilization, we're trying to increase revenue, we're trying to improve accessibility of the patients. All of that is correct. But now, for example, you read this definition. Lean approach is the increasing customer value by eliminating waste throughout the value stream. What does it mean?
I got it.
Yeah.
The sequence of activity.
The sequence of activity, excellent. So value stream is your process, basically. So you look at the sequence of activities you're doing, and you look at where the process currently flows, you identify then waste, and we will see an example on that.
Mainly about steps, is that correct, Zahra? It's the steps within the process.
Yes, so you look at the process and you look at the overall. So let's say, going back again to the discharge process, you'll say discharge process starts from where? Starts from the physician identifying patients for discharge, or let's say even it starts as back as we always say as the admission. So it is explaining to the patient how long they will stay. That is step number one. And then preparing the discharge requirements, and then writing the discharge summary, and then involving the case management and the nurses in this, and then providing patient education, getting the patient their medication, all of that till the patient left. So you look at the whole process. Then you identify waste. What could be a waste in the discharge process?
Waiting time.
Waiting time. What is usually patients are waiting for during the discharge?
The doctor to put the discharge summary, for example.
Discharge summary, yes, because we're discharge. What else?
Sometimes
medication for medications.
Medication, yes.
Waiting for the relatives or their caretakers to come and take.
The caretakers to come and take them, yes. In the process itself, maybe the patient was not even told from the very beginning that they will be staying for 3 days, for 2 days, for 1 day. So by the time there is a wasted time of explanation and setting expectation. So you look at the whole process. Usually, like they draw a very detailed process steps and mapping, and then you look at the waste. Okay. It's they say the philosophy is continuous improvement through empowerment. Usually, lean approaches can be done only in the area of work that you are performing. And then here it says we spend 75 to 95% of our time doing things that increase cost and create no value for the customers. Okay. Now, these are very important terminologies for the lean management. Anything you talk about that's lean management, these are important things. So, for example, value added, it says it's a step or activity that the customer is willing to pay for. Okay, so I'm going to continue with the discharge example for today. what is a value added activity in the discharge process that the patients are willing to pay for?
Maybe medication.
Medications, definitely.
Consultation fee. Is it?
No, so discharge. We're talking about discharge.
So,
For the transportation.
It's not usually part of your discharge process unless you're providing transport.
Like ambulance or
Yeah, for the
ambulance
patients who
transport
require
also.
it, exactly. So that's why we said
Appointments.
the appointment, the follow-up appointments, which is usually actually the biggest part will be your discharge summary that describes the process of the case as well as the medication and the prescriptions, and then the patient's freedom to leave. So these are, you look at the process. The education is, for example, a process that the patient is willing to pay for. The availability of items, for example, if they require crutches or any kind of medical equipment, would be a step that his patients are willing to pay for. Okay, and then it says non-value added activities is a step that does not directly contribute to adding value. So think about anything that is not adding value in this process. So discharge, the actual physician writing the discharge summary, is it a value added or non-value added? The discharge summary itself, like when we are part of a hospital, does it matter to me as a patient to get the discharge summary or not?
Sometimes. If I'm gonna utilize it somewhere else to get a second opinion.
Okay, could be.
And if the patient, whatever treatment was given, whatever surgery or medical treatment was given, that is the summary, which he should know.
Yeah,
The patient
okay.
should
Let's talk about should know, should not know. Okay, if you think about you or your loved ones as patients.
I don't think really, Zahra, it's a matter.
Yeah?
Because it's not comprehensive where the patient can use it and
Even if it's comprehensive, it talks about history, right?
exactly.
I know exactly what was done to my patient, like unless I need it for like a extended care or some other practices. But I know exactly, for example, what was done to my mother during the hospitalization. So this discharge summary is basically a waste to me. Maybe. Yeah. So you look at the majority of the patients and you see whether it adds value to them or not. For me, what's most important is that I get the prescription, I get my medical equipment if I need them, and I'm told when is my next appointment. So the discharge summary is basically not in the list of super important things. and then this could be considered non-value added, but actually it is this one, which is value enabling or non-value added essential. So what they're saying here is that it's a step that's considered a waste, not adding value to the outcome, but is required either because of regulation as a prerequisite to completing value added step. So the discharge summary, صباح الخير يا أمل.
صباح الورد.
Yeah. So the discharge summary in this case is a non-value added essential because it's required by the JCI, DOH, hospital regulation, everything. Sorry guys, I'm gonna mute you. Okay, so that's why we say they are maybe to the customer, to the patient, they're not willing to pay for it, but it is necessary and we have to do it for them. So it's a step that's considered a waste, not adding value to the outcome, but it's required because either of regulations, as we said, and so on. MUDA or waste. So again, this could be part of the exam. They will ask you the MUDA is, or MUDA is what? So MUDA or waste is an excessive or unwanted step, resource, or activity. Anything that's considered excessive, unwanted step, mainly all of your non-value added steps that are not essential to the process are considered waste or MUDA. Clear?
Yes.
Yes.
Now,
Zahra,
hello.
so what's the difference between the second point and the third one? Non-value added or non-value added?
Non-value added, essential. That's why we said, for example, we were talking about discharge, and we said one non-value added essential is the discharge summary. The hospital has to give you a discharge summary, otherwise they will fall in trouble, for example. But maybe you as a patient does not require it. Let's think, for example, the admission or the if a patient is going to see, the classic example is if a patient is going to see the doctor. What is the value added? What is the thing you're willing to pay for if you're going to see the doctor in the clinic? Let's say you're feeling sick and you want to see the doctor. What's the value added activity that you're willing to pay for?
Maybe the consultation fees.
The consultation. You want, the end goal is to see the doctor, صح? What is non-value added stuff in that process?
Sometimes vital signs, wallahi Zahra.
Vital signs, yeah.
Yeah, from perspective of patient. I'm feeling well, but I need to see the doctor.
Okay, so vital signs could be non-value added. What else?
Consent.
The consult itself?
Consent.
The consent. Okay, yeah. If you do the procedure, the consenting might be non-value added. What else? In your way to go to see the doctor, what do you have to do? So let's map the process.
Security issue.
Security, parking, security. You go and you register. Let's focus on the direct process. You go into
Waiting area.
Waiting time.
You register, you wait, you do vitals, you wait, yeah, or seen by the nurse, and then you wait, and then you get to see the doctor, and then get your medications and leave. So value added, we said, is the consultation and maybe the medication part, right? Because that's what we wanted. Non-value added is all the waiting that's involved in the process. Now, the nursing vital signs and the registration process are considered value enabling or non-value added essential. Like, it's important, we have to do, like, you cannot see the doctor if you don't register, right? Right?
True.
Yes,
So,
yes.
unless you register, this is a value enabling. So for you to go to the next step that's important to you, you have to do this step, which is register. For you to go and see the doctor in the clinic, the policy requires you to have vital signs recorded, for example. So these are non-value added to the patient, to the value, to the customer who's getting the service, but they are essential. They are based on regulations or a prerequisite for completing the next step. Is that okay, Salwa?
Yes, clear.
Okay. You're welcome. Then these are the...
In the previous example, where is the wait then? Where is Muta?
The waiting.
Yep. The waiting. Okay, so it's linked with non-value added.
Yes, it's totally non-value added, and it's not essential. Like, why don't we have a process where the patients can actually go and register vitals, see doctor? Yeah. So the waiting is something that, and that's why most of the organization focus on eliminating the waiting as much as possible. Usually they are non-value adding and they're not beneficial to anyone. Okay. The process of waste, the 8 processes waste of limbs, sometimes they're 7, sometimes they're 8, but this majority are described. Defects. When you look at any processes, you look at defects. So anything that's broken, that's not working well. Let's talk about, again, the discharge process. What could be defects in the discharge process? Or a defect that affects the discharge process? Anything?
The
Maybe
order.
around the cow is not working. So this is this is a defect.
Yeah, if the computer is not working, sorry, Ruby, you wanted to say something? Was it Ruby or Rincy? I heard someone trying to say something.
Rincy, maybe.
No, not me.
Okay, fine. So defects, as we said, this could be anything that breaks down in the process. It could be your computer. It could be salamtak downtime. It's one of the defects that really impacts the discharge process greatly, right? Because if there is a downtime, I can't do much. I can't document. I can't even see the patient records. So defects is anything in the process that's broken, that's a defect. Usually, if you look at manufacturing, so think of these were initially started from manufacturing, right? Think about while you are manufacturing, let's say you're creating juice bottles, and then some of them come up half full, or they come up broken. Somehow the machine made them defected. So this is defect. Anything that's a defect is waste because automatically you can't use it. Then overproduction. What could be general examples of overproduction in hospitals?
Like in the discharge process, let's say like the patient will be seen first by a specialist, and then the specialist will call the consultant, and then consultant to come to see the physician, to patients for the discharge. So it's a lot of steps that has been done to discharge this patient.
Actually, that one you gave is an excellent example for extra processing. Process after process, this one will see assess, this one will see assess, this one will see approve, this one will see. So these are processes, extra processing.
Overproduction could be like papers, discharge paper,
Discharge
then
paper, education.
section, then
Yes, it's
Instead of
all the unrequired records, documentation, papers, printing, and stuff that might not be needed or could be consolidated, for example. And for example, I believe our discharge summary currently, if you look at it, out of 3-4 pages, the most important information might be only 1 or 2. But you see a huge list of all the labs you've done during the hospital stay. You see a whole list of all the medications you got during your stay, after your stay, before you even came into the hospital. So all of these things are considered overproduction. Additional information, things that are produced and available, but it's not even needed. Again, in a factory situation, it will be, as you can see, multiple boxes. So producing more than your capacity or more than what's needed for your customer. Okay. Waiting. Everything in healthcare involves waiting. You are waiting for your discharge summary, you're waiting for your records, you're waiting for your medications, you're waiting for the person who's going to give you the education. All of that is examples of waiting. And in admissions, in discharge, all of what we talked about, the waiting to see the physician, waiting to be admitted, all of that is waiting. A non-utilization of talent could be an example of what? It's a general element of waste.
appropriate.
If you have an experienced surgeon in robotic surgery, but due to the unavailability of robotic machine, you are not utilizing the talent of that surgeon.
Okay, so it's not because of the unavailability of the robotic. You have the robotic and you have a talented person who can use it, but for some reason you're saying, for example, oh, this department is not yet privileged to use robotics, even though they have the knowledge and expertise. So then utilization of talent is that you can utilize them. If it's because of organizational limitations where you don't even have the thing, then this is not non-utilization of talent. This is not unavailability of the requirement. But if you have the talent and you have what they need to use, and yet you don't use it, that is when it becomes non-utilization of talent. Okay. Again, any example that talks about, for example, if we say,
can I ask a question?
Sure.
Yeah, talent here means a person or the unit or department. Like HDU, we have HDU, which is well equipped and we are not using. This is talent also, or you mean per individual?
Actually, majority here, when you talk about talent, talks about people.
People.
Yeah. So let's say, for example, now we have an
UCT.
expert. What's that? UCT. Yeah.
The UCT was
So we
like
have
non-utilization of a talent.
UCT is the urinary catheterization team, a team of experts that can help with any difficult urinary catheter processes, and not calling them, not utilizing them, not consulting with them when you need them is an unutilization of talent. So anything talent is usually related to people. Let's say in the example of the discharge process, if we have, for example, we have diabetic educators and we have a diabetic patients, but we don't call them to give the education on the management of diabetes and so on. So that is non-utilization of talent. We have the talent, but we did not utilize it for this patient, specific patient population, for example. And then transportation is anything that requires moving using a transport tool, because there is transportation and then there is motion. So transportation is moving patients from point A to point B, taking them from the unit to the pharmacy to the ambulance and all of that. Usually, most of the transportation processes are considered a waste. They are linked. They're similar to waiting, but mostly it's considered non-value added essential. You need to be transported somewhere or to be moved, specifically if it's about patients, to be able to access the care elsewhere, or, for example, get your diagnostics done and so on. Inventory is anything that requires storing, counting, monitoring, expiry dates. Anything that involves inventory is considered a waste. And that's why in the units, remember, we have a bar level and we need to only keep enough to maintain the work of the unit, but not too much that things might get expired while they are with us. So anything that requires inventory usually is an example of waste. Motion, what could be an example of motion in healthcare that can be considered a waste?
Going for each
Assignment.
test in different areas, moving. The X-ray will be in one direction and the lab will be in another direction. So patient are walking too long.
Exactly. So having the patient journey not planned well or not accessible to patients is an example of motion. Anything that requires moving from one place to another. What about a classic example that's given this usually is when the nurse has to prepare a dressing, the dressing items. So sometimes if the store is not arranged very well, if it is not clearly laid out, items, what will happen is she will try to get the dressing set from up here, get the saline and the sterile cleaning solutions somewhere from the bottom, walk a little bit to the other storeroom and get let's say the incontinence sheet and stuff, and go somewhere else and get the swab. So maybe there's an order so all that motion required is considered a waste, and that's why they say when you're arranging your store areas, you should work on making sure that they are lean as possible, that it does not require a lot of motions. Similar equipment that might be needed for similar procedures could be lumped together in the same area as much as possible within the store. Extra processing is the example that Riyad already
motion,
said. Go ahead.
Zahra, like motion, like the way how to minimize motion. What's that? Cluster care. So if you are
Yes.
entering the patient's room, collect everything one time, then
True.
enter.
True. Yes. Cluster care is example of reducing the motion because you don't have to come back and forth from the same patient room. Also, the assignment, if you are trying to assign the nurses to take care of the, a couple, especially in SSMC, to take care of similar rooms that are next to each other, is an example of reducing motion instead of giving her a room at the beginning, at the four corners of the unit, which is going to be involving a lot of motions and a lot of wasted effort to move from one place to another. For extra processing is the example that Riam gave, when multiple people, for example, has to see the same patient for the same outcome. That's considered extra processing. Okay. This is the lean fundamental. Now, any lean process that you talk about, remember, see, like for example, this is the process before you implement lean, and they're saying that this green, the green color is the value added, and the blue one is non-value added. Okay, so you see this process had a lot of non-value added in between the value added steps. The aim of lean is to reduce waste or eliminate waste, so cut down on the wasted time, and that will make your process shorter, leaner, and better value adding for the patient. Okay. So lean focuses on eliminating waste in and around the process. Always remember this. Before it was this much, it was all of these. Let's consider patient came in, waited, registered, waited, seen the nurse, waited, seen the physician, waited in the pharmacy, got his medication from pharmacy, and then left. So these are all non-value added, a very long process that includes value added and non-value added. When you try to cut down on the waiting in between the different steps, that's when you give real value. So same value, what is the value? Remember, we said value is in the green part, the green color. So it's the same value. We still have 4 green colored blocks, but they require less time and resources. Which one of the quality dimensions is this one? Same value, less time and resources?
Timeless.
Efficiency.
Efficiency. Aywa, who was that?
It's Miriam.
So remember, this is the classic example of efficiency. You will check how much, the value you are providing, how much resources you are using, and that is efficiency. Riham, you said timeliness. It is timeliness in this case because I'm talking about waiting time, but this could apply to anything. Could apply to waiting, could apply to the value of items, could apply to the number of storage items in your consumable box. All of that are considered examples of lean management, because you can use lean management in space management. So this is becoming more efficient when you reduce the waste. Okay. Six Sigma focuses on eliminating defects in the process. Any defect, any issue to improve your processes, if you eliminate defect, it is Six Sigma, or eliminate the variation is Six Sigma. Eliminating waste is lean. Okay. Now this is also an example of the lean. You all know the 5S, right? Have you been part, or have you ever used the 5S?
Yes.
When did you use it? For what? Give me an example of using 5S.
To organize. For example, if I want to organize my store, I'll use the 5S.
Yes, storage. To clear the storage areas, you use the 5S.
In the equipment to arrange. In SSMC.
Yes.
Store arrangement we did actually, like the before.
So it was part of the nursing model of care, SSMC nursing model of care, where they used the 5S principle to arrange the equipments in the units, as well as the storage before. So the 5S is just because it is 5 words that start with S, the letter S. It was a Japanese origin, but then they also used the English words that reflect the 5, all start with S. So it starts with sort. So whenever you're trying to arrange something, start by sort. Sort everything, make sure that things that are similar to each other are in the same place. Set in place, now define a place, put everything in its designated place. Shine, clean the area, make sure everything is clear, cleaned, and so on. And then standardize. Standardize is usually by placing labels. This is where we put things by placing, for example, for the equipment, they've used the markings on the floor to reflect the the location for each equipment and so on. So everybody going forward will make sure that they use the same place for everything. And part of standardizing is also having a checklist of having someone review how well you are maintaining your place. And this is part of the sustain. So sort, set in place, shine, standardize, sustain. Examples of how I saw this come in the exam is that they ask you, this place is in the process of implementing the 5S process in their organization. The process in which they audits are done to ensure compliance with the 5S methodology is part of which one? So then you would say, in this case, for example, it's part of sustain. Sustain includes all the audits and all the measures that you can do. Okay, so this is the examples of the 5S in the organization. This is 5S in the storage place, for example. So okay, I'm trying to find something, but I can't find it. Okay, I'm not sure if this is a hammer. Like, let's consider this is a hammer. In the first picture, can you find this item?
No.
Yeah, this is usually how things are. When things are not arranged, it's more difficult to find, more difficult to access. And this might be, think of places in the hospital that are like this, for example. And then this is when they sorted everything. Then they set them in place, and you can see the markings on the floor for each one of the equipments. Then they standardize. They put in all this specific shine first shine, which is clean, standardized by putting labels, making sure everybody knows where everything has to go. And then sustaining is usually going to be done by audits because it's human nature. First 2 days, you will put them in place. After that, you will start putting it wherever. So unless you have someone monitoring and making sure that this is being followed, it will not stay as clean as and arranged as this one. Okay? You're okay with the 5S principle?
Yes.
So 5S stands, what are the 5 S's?
Sort, set in place,
shine,
shine,
standardize,
standardize.
Sort,
sustain.
set in place, shine, standardize, and sustain. Yes. Okay.
And safety also added, no? Safety.
The newer one has the safety in it.
Yeah.
But the majority or the most of the literature just talks about the 5S, because then you go into the 6S principle. Okay. 6 Sigma. Now this is, we moved from the lean. Now we're going into the 6 Sigma, which is a new quality improvement methodology. So the 6 Sigma itself is a statistical measure that expresses how close a service comes to its quality goals. We'll talk about this in the next slide. It was developed by Motorola, and the aim of the 6 Sigma is to eliminate the number of defects to 0 from any process, product, or service. these are the sigmas. This is how the sigma symbol is. And you can say this is 3 sigma, 2 sigma, 1 sigma from both places. And when you say 1 sigma, you can see 1 sigma is just the middle of the the chart here. Okay. And usually 1 sigma is 68.26% of your most of your process limits. Okay. And then the 2 sigma is 95.4 or 95.46% of your total population. And then your 3 sigma is going to be 99.73. So let's say, for example, the waiting time. Usually you will have, depending on what sigmas or what data you're looking at, 68% of your patients will be waiting at, if you're achieving a 1 sigma level, then you will be 68% or less. A 2 sigma level means 95%. A 3 sigma is 99.7. Okay. As we said, it's a statistical measure that expresses how close a service is to its quality goals. So the more sigmas, is it better if it's more sigmas or it is worse if you have more sigma?
Better.
Better.
The more sigma is, because your quality goal is here at the end, they consider them.
No.
So if you, Salwa?
No, if more sigma means
I think
it is not good, no?
More sigma means good percent.
Deviation is more. That is the meaning, no?
Say that again? No. More sigma is deviation is less. So remember, I gave you the example of the waiting time. If you achieve 1 sigma, that means only 68% of your patients are meeting the quality goal. So 68% of your patients are waiting for less than 60 minutes. The more sigma means now you are having more and more of your patients meeting the targets. Yeah. So the more the sigma, the better. And that's why the name of the methodology is actually the 6 sigma and not like 1 sigma or 2 sigma or 3 sigma. Okay. So the higher the sigma, the better the process.
There will be questions like with like this, like anything
no,
like related to 2, 3.
This is just the beginning. Hold on, there is more.
Sahra, then why this is called as 6 sigma? Because it's showing both the sides. So it is 3 only, no?
No. This is only 3. 6 sigma is going to be even less.
Oh, okay.
Yeah. So here you will have 4 sigma. Here you will have 5 sigma. Here you will have 6 sigma. So can you imagine how far is this from the line? It's almost identical to the line when it becomes 6 sigma.
So are these standardized? Like for 1, it is always 68, and for 2, 95, like that. It is.
So in the 6 sigma strategy, and this is based on the most US business, so the numbers are not the same. You usually would look at your data. Remember, we said it's a statistical terminology. So you will look at your data, and based on it, you will evaluate it. So in the most of the US businesses at the time, they found that 6 sigma or 1 sigma, which is, we said it's the 68.26%, yeah, you have 30.9% is defect free. Okay. So here, whenever they talk about 6 sigma strategy or quality improvement process, they talk about this. It's very important for you to remember this, DBMO. Anyone knows what's DBMO? DBMO is defects per million opportunity. So they don't talk about hundreds, they look at million opportunities, yeah? So they will say, if you achieve a 1 sigma level, then you are هذا هانية.
لا كذا تجيبوش كمان يجي الواحد يقعد عند جريه ما بدي اجيبه.
The 1 sigma level means you have almost 700,000 defects per million opportunity. So consider if you are a factory and you are producing million boxes of products or million bottles of water, let's say, out of the million, you will have almost 700,000 defects. Yeah. So only 30% of your products are good to be used. Does it make sense?
Yes.
Okay, so this is just numbers. If it becomes 2 sigma, that's why we're saying the better the sigma, the higher the sigma, the better. If it becomes 2 sigma, going back here, 2 sigma, we move from 68 to 95. Wow, 95 is good. Usually when we get 95 in our KPIs, we say it's good, it's excellent. But 2 sigma still says there is 300,000 defects per million opportunity. So only 69% is defect free. Is it still bad if you are producing water bottles to have 300,000 out of the million defected?
Yes, 30% is almost defective.
Yeah. So it is still very bad. Yeah. Because usually if you hear, oh, we are 95%, you will feel happy. But if you look at it, just a minute. 1 second. Okay, guys, I think I lost you for a while. 1 second. Okay, sorry, guys. So what I was saying is usually when we see in our KPI that we achieved 95%, we are like, wow, we are okay, right? We don't have to improve anything. We're already achieving 95%. But if you look at it per million opportunity, that's 3,000 possible mistakes or defects in the million opportunity. Okay, we go to the 3 sigma. The 3 sigma is 99.73. What do you want more than that? Yes, it's 99.73%, but that means if you count it per million opportunity, it is 66,000 defects. Again, if you are the owner of the water bottles production company, will you accept this? Would you say, mashallah, I am 97, so I'm okay?
No.
Factory owners, what would you say? If you're creating 66,000 defected products, of course you will not be happy. And then you move to the 4 sigma. The 4 sigma is still 6,210 per million opportunity, which means 99.4% defect free. 5 sigma is out of million opportunity, you still have 233 defects. So again, if we're talking about that factory that's producing the water bottle, so you have 233 defected water products that's wasted, which means that 99.98 defect free you are. And then the 6 sigma is where you have 3.4, only 3.4. So again, go back to the factory example. Imagine that you are producing 1 million water bottles, only 3.4, let's say 4 of them or 3.4 of them are going to be defected. The others are going to be completely fine. And this increases your percentage, the defect-free percentage, to 99.99997%. And this is the goal of the 6 sigma strategy, is to reduce waste or to eliminate defects to make it less than 3.4 defects per million opportunity. Clear so far?
I have a question, Zahra. I'm
Go.
not clear from the previous one, actually. It looks like standard deviation, and while answering some of the questions, I found the answer was 68, 95, 99. And the question was purely about standard deviation. How this can be different
Yes.
from standard deviation?
This graph, again, we said Six Sigma is a statistical measure. So it does focus on, it uses elements from the standard deviation and stuff like that. This graph is to show when we're talking about a sigma level, this is how you can visualize it in a graph format, which is, again, it's a statistical measure, so it will have the same elements, or it is part of the, usually when you're talking about your control charts, your measures and stuff like that. So it is exactly the same, but when you talk about Six Sigma, the only thing is that it focuses on the defects per million opportunities. So I'm not focusing on the compliance part. I'm focusing on how much defects I'm having or how much non-compliances I'm having per million opportunity.
Can I add Zahra?
Say that again?
Can I add Zahra?
Go ahead.
Actually, the Six Sigma, usually you will have Riham, your standard deviation. Yani standard deviation, it will be calculated. However, only like what Zahra said, it's just only how you are looking to the method of calculation, the units. Yani, your standard deviation, let's say maybe 1,000 per 1,000 patient days. However, in the Six Sigma, you are calculating with millions defects. Like it's just only the matter of the units of calculation. However, the standard deviation, it is there. The standard deviation, it is the same. You should have your standard deviation either to the negative or to shifting negatively or shifting positively. But it's just a matter of the how much per units you are calculating the defects. Sounds
So
okay?
it's correct the way you said, Hania. So it is, again, when we say it's a statistical measure, it will follow the standard deviation and all of the different statistical measure requirements. The only thing, as we say, the difference between Six Sigma is that it focuses on the defect per million opportunity. This graph is for everyone to understand what's a sigma first, and then how far it is from, when we say 1 sigma, 2 sigma, 3 sigma, how is it represented in a graph? Is it all right?
Here
Zahra, يعني Six Sigma only dealing with millions. If you have customer exceed millions, you can use Six Sigma.
Yes. And we'll talk about this in a minute. Sorry, Vidya, you were saying something.
Yeah, the standard deviation will be more when it is 1 sigma than 2 or 6.
Yeah.
Isn't it? The deviation will be more when it is 1 than from 4 or 5.
Exactly.
So towards the curve, when it is near to the this axis of x-axis, it is more meeting the deviation. And I mean less deviation here.
Deviation,
yes. That's
so
why sometimes they are
standardization.
using it actually in the healthcare. They are using 1 sigma. So they are using it in the finance. They are using it. I think also in the patient population, they are using Six Sigma. However, they are using 1 sigma only because sometimes the deviation, it will be hard to achieve 3 sigma.
Yeah. So we'll talk about, for the rest of you, sorry, we'll talk about the standard deviation and the topic that Riham is talking about when we talk about statistical measures, but it's the same. It basically is the same thing. The only thing is the representation, because when you hear Six Sigma, sometimes it doesn't make clear sense until you look at it in a graph format and you understand that the sigma is how far is the goal or the score that you achieved from the central, the average number, for example. Okay, so somebody asked now, we only think about Six Sigma when we have million opportunities, right? So why do we need to use it in the hospital? We don't have a million opportunities. Do we have any million opportunities in the hospital?
Yes, we do have. If we look into patient days, device days across a year.
Okay. If you look at patient days and device days, that's excellent.
Or money, even cost.
Money and cost. Even
Look to patient procedures at the hospital, also how many procedures done for each patient
true.
without errors, without defect.
Excellent. Even if you look at something as simple as the patient identification, how many times do you think we do patient identification in the hospital? So think about it. We have all of the patients who are seen in the emergency, around 500 a day. We have all of the patients that are seen in the clinic. Let's say we almost see 1,500 a day. We have all of the patients that are inpatients for a certain day. Let's say that's also around 400 patients. And then for all of those patients, whenever we are administering them treatment, or we're doing for them a procedure, or we're doing for giving them a medication, or any interaction with those patients will require us to identify them again and again and again. So think about one patient who came to the emergency department. Let's follow that journey of the patient and think how many times that patient is being identified. They walk in, they're identified by the registration person to register them. They go inside for their vitals, they are identified. They go inside for their to be allocated a bed, they are identified. They are, the physician comes in to assist them, they are identified. The laboratory person comes to collect their blood, they are identified. The nurse comes to give them their medications, they are identified. She goes back after some time, there's an IV fluid, she comes back and she identifies the patient. The patient is sent for an X-ray, they are identified. The patient comes back to the room, and now we have to check his vitals again. We're going to make sure it's the right person so we can document it, and they are identified. And all the way till discharges. That one patient maybe had more than almost, let's say, 50 opportunities within which the patient was identified. Think about, this is one patient had 50 opportunities. When you had that number of patients that we talked about per day, and all of them having procedures, assessments, and so on, how many times do we identify them? Do we reach million opportunities? Do you think we can reach million opportunities? Easily we can reach million opportunities. Think of the same thing. How many patients we give medications to? We give them, some patients have medication 3 times a day, some patients have 2 times a day, some patients have IV, they have stat orders, they have, so think everything that we do, when you think about it, you might think it's a small number of opportunity, but you really, when you think about how many of our customers, our patients are getting this specific process, then we easily go into the millions of millions. So do we have million opportunities? Yes. As Riham also said, when we talk about device days, when we talk about this, patient days and stuff like that, we easily go into millions. So if the processes at the process level, we have a lot of processes, even as a healthcare, that reaches to the million opportunities. And the aim is to reduce the mistakes. So think in a place where for every million identification process, you only have 3.4, for example, issues. For every million procedure that you do, you have 3.4 defects or challenges or issues in it out of the million procedures that you do. So is Six Sigma applicable to healthcare? It's very applicable because you have a lot of processes that are that happens in millions of times. Even sometimes in a single day, you could have million. Look at the documentation. How many clicks do we have per day? If an IT person is here, they will tell you we have more than million clicks and million documentations and million documentation points that being entered every day. So Do we have an opportunity to use Six Sigma? Yes. And what did we say? The goal of Six Sigma is to do what?
To reduce the variation.
To reduce the variation, to eliminate defects.
Defects.
Yeah. So defects and variation in the process. And the goal of the lean is to what?
To eliminate waste.
Eliminate waste. Okay, it's very important that you remember this. One of the Six Sigma strategies is that anyone has questions?
Sahra, for the Six Sigma, no, when we are giving some examples, even that 3.4 defect is also not acceptable in certain conditions. No? Like if when we said patient identification, even 3.4 defect is not acceptable there.
True. But now, if you think about it, when we do, okay, let's think about hand hygiene. Every patient has the 5 moments of hand hygiene, and we almost go across that 5 moments of hand hygiene 10 times a day with the single patient. So consider it with all of the other patients that we're having. Today, if we say, well, we achieved 95% compliance with hand hygiene, we'll be happy, right? Wow, mashallah, our unit is doing great, right?
Yeah, but we are only at 3 Sigma.
We are only at 3 Sigma. So how many, we could still have 66,000 opportunities of defects. And this means 66,000 opportunity for us to transmit infections to patients and to give them diseases that they do not need, right?
Yeah.
So if you really think about it this way, you will think that everything that we do in a hospital, like even the 3.4 is not acceptable, but this is the best they could come up with as closest to zero as possible from the Six Sigma. After that, no matter how you increase the Sigma, the changes or the capabilities will be more difficult to grasp or to address. So 3.4 defects per million opportunity is what the Six Sigma is aiming for. But if you want to be the perfectionist, zero should be ideally the case. But sometimes you can't reach the zero level.
So is this fixed numbers?
Yes, the 3.4 million, the 200, yes. And this usually comes up in a question. The aim of Six Sigma is to reduce errors to be less than, and then you say 3.4 million opportunity or 99.997. Okay. Now moving on. So for the Six Sigma strategy, they use the DMIC methodology. DMIC is for D for define. So define the problem, define the objectives of the improvement. What do you want to do? M is for measure. Now, what do we need to improve? You start collecting the data. Remember, we said that it's very statistically driven quality improvement methodology. So you have to measure, you have to have your control chart, your statistical analysis, your standard deviations. You have to define your numbers and you have to define your sigmas and so on. And then you analyze your process. So now you know your measures, and then you analyze your process, the factors influencing the process. You do your fishbone diagramming to see why we are having this specific, for example, a score, for example. And then I is for improve. After the analysis, you decide what needs to be improved, and you implement your improvement plan. And then C is for control, which is where you continue to measure and sustain the improvement and ensure that it doesn't deviate. And every time you do a DMIC methodology, you continue to do them with the aim to reach to the 3.6 or 3.4 defect per million opportunity level. So you could repeat the DMIC multiple times to actually achieve the same target. There is another one which is the DMIC or the design for Six Sigma DMADIV, but we're not. It's not used for improvement. It's mainly used to design process and services under Six Sigma. Okay. There's one also. Okay. Now we talked about the different quality improvement methodology.
Sahra?
Yes, please.
Yeah. So the lean is always we use the process stream mapping, right? In lean, because we want to have efficiency.
Yes.
To improve the efficiency and the cost and the outcome.
So lean, remember, always
Sigma,
lean, you eliminate waste.
Waste. Yes. Eliminate waste means you're improving the efficiency.
True. Yes.
Yeah. In Six Sigma, we use different tools, which is one of the examples is the DMAC. It's to eliminate the defects in any of the processes, right?
Yes, to eliminate the defects and reduce variations is a key terminology under Six Sigma. But when
there is something called
for example, in define, during the define measure, you could also use elements of process elements of lean, where you do your process design, where you do your analysis, process mapping and diagrams, and you go through it to identify where it's the waste happening. Lean, there's something called value stream mapping, but I think I believe we will mention it later within the classes. The value stream mapping is a very commonly used lean methodology template where you draw the process from beginning to end. It's not only a process map. You draw the whole process, and then you draw all the waste elements, and then you, even with time. So you would say the patient comes in and waits for registration. How long do they wait for registration? 10 minutes. Then they register. After the registration, they wait for 20 minutes for the nurse. And after the nurse, they wait for 30 minutes to go inside and see the physician. And after the physician, they go to the pharmacy and they wait for another 60 minutes. So you really draw everything with clear timestamps. And then your aim is to reduce all of those waitings, as we say, and then come up with a shorter patient journey to improve their process. But within the Six Sigma, so this is the model of the Six Sigma. Underneath it, you can use, for the analysis, you can use fishbone diagram, you can use, other tools and techniques that we talked about within your analyze, for example.
Because nowadays we do the lean Six Sigma. They combine both strategies together and they make it one form.
True.
It's actually the DMAIC itself. It's that you can use all kinds of models of improvement, either fishbone, either lean, either 5S, whatever you can use under the DMAIC. It's the big umbrella. It's the DMAIC. It's the big umbrella for all of these improvement methods.
Yeah. So remember when we talked about the BDCA, we also said the same thing. For your plan, you can use certain tools and techniques. For your the doing or your action plan, so plan, do. For the implementation, you can use certain templates and tools. For your analysis or checking, you can use certain statistical analysis tools. And then for your sustaining, you can use. So there's a difference between the quality tools and the quality improvement methodology. DMAIC, BDCA, they are methodologies for quality improvements. Within the methodology, you can use multiple tools. Does it make sense?
Yes, Sahra, that means PDSA, DMAIC, and those things, improvement methodology. Okay,
yes.
What about Lean and Six Sigma? They are the tools. So, no.
Lean. So Six Sigma uses the DMAIC methodology just to kind of make it into an easy to remember acronym. But your aim, remember, your aim in the Six Sigma is to achieve the Six Sigma level of 3.4 defect per million opportunity. So using the DMAIC model methodology. So we talked about, remember now we talked about BDCA, we talked about the Xerox model, we talked about all of those are models of improvement, and within the model you can use multiple tools. The tools are not specific to the model. Under the model you can use any tool. And actually, if you really think about it, all of these basically are saying the same thing. You define your problem, you measure it, you analyze it, you improve it, and then you sustain it. Can, do, check, act. All of them basically going through the same cycle of improvement, but then they called it's multiple or different terminologies based on the major or the person who came up with the quality improvement methodology. For Six Sigma, for example, it was very important that they define or they keep the measure specifically separated, because the whole thing you have to calculate to see what's your current defect level, which sigma you are standing at. You have to define all of that. And after you define which sigma, you then try to increase the sigma. So maybe today you are standing at 3 sigma, and your goal is next to move to the 4 sigma. After the 4 sigma, now you are stable for some time. Your next goal is going to be to move to the 5 sigma. After the 5 sigma stabilized, you now our processes are giving you a 5 sigma process. Then you go on and you try to reach to the 6 sigma. For them, it was very important that they specifically point out the word measure, because they really focus on the statistical analysis as part of their quality improvement methodology. Sorry.
Zahra, sorry, I'm asking one question. Like, I don't know if it is in the book or not. So, what is the A3 DMAC? Is it part of this course or not? Because I just want to correlate with the A3 thinking approach for the DMAC.
I remember hearing about the 3A, but I really can't remember it right now.
So okay, so maybe it's not a course. Maybe I remember it from different course.
It could be,
it's
but
a methodology. The A3, it's a methodology. It's one methodology that DMAC. DMAC always it's a big umbrella. So you can put your DMAC project on A3 for the people. It's straightforward. It will define the problem, what statistical methodology you use, and what is the result.
Okay. So
it's like a kind of form, or what, Hania?
It's a kind of a symbol, because usually when you are doing Six Sigma DMAC, it's a huge statistical processes, and it might go through deep methodologies. A3 usually is like a summary of whatever you are doing, and it's more easy for the people to understand it. You can say it's a kind of like a form with a certain just a straightforward define your problem, what statistics you use, then what happened, and what is your result.
Thank you.
I think we are using it. Yani those boards, what you are using in some of the units, it's A3 actually. It's A3 methodology, or what we can call it, form.
It's kind of a visualization form of the DMAC process.
Yes, we can say so. Even for BDSA. Yani, I remember we used to use the A3 even for BDSA. Actually, BDSA, it's like a small definition of the DMAC. It's like a small process. Even sometimes under DMAC, you might use maybe 2 or 3 BDSA for different problems, but you are under the big project which you are working at, because sometimes you will find out that you need more than BDSA to solve more than one problem at the same time, just to go through with the whole project of Six Sigma. So sometimes you are using more than methodology to come up with the final, and this is actually done in the hospital many times for the past 2 years. I think maybe Zahra, she can maybe provide examples that they did a lot of projects where they used multiple BDSA to come up with the final result.
Thank you.
And for improving the registration, for example, I remember one big project was like improving customer service, especially through the registration and the process of seeing the patient, where they used multiple BDSA to come up with the final changes.
Okay, can you see my screen?
Yeah, this is the three thinking.
Yeah.
How to present the form, your problem,
Yeah.
your statement.
So very quickly, what it says, it's just a way to reduce the amount or to specify the amount of information you want to measure. You then create some kind of a template for you to present. An A3 comes from the paper size A3. So here, define under define, you talk about the project title and then the problem. Under the measure, you show the statistical measurement tools here. And then the analyze, you show how, what's the cause analysis for your problem. And then under the improve, you try to evaluate how well you're doing with your outcomes. And then you're planning an implementation of the correction actions. And then here is your continuous data plotting of your improvement, as well as the standardized, any standardized tools or techniques that you would use. So A3 basically focuses on the presentation of the of your quality improvement process or project.
Thank you, Sahra. And Hania as well.
Thank you. Okay. Now we move to performance measurement and improvement. So hold on, one of the basic principles. Okay. So continuing about the improvement processes for the quality management. Here they're saying one of the fundamental aspects is that any process can be improved. So you shouldn't say I cannot improve this or I cannot make this happen, because the idea is that everything, even if you are at a high sigma level, you can still improve it to make it even better. So the organization leader should define criteria that will be used to choose the improvement or prioritize it amongst other suggestions. Last time we talked about, did we talk about how to prioritize improvements? I believe we did. Anyone remembers?
No.
Try to think. If you have multiple things that you're trying to improve,
we look to high volume, high risk.
Yes.
Yeah, the probability and likelihood.
Yeah.
Exactly. So for prioritization, you look at high risk, high volume, problem prone, customer impact. There was a cost. There were 5 of them.
Yeah.
And then based on it, you decide, which one of the opportunities you will start working on. And then it's talking about developing a performance improvement action plans. Okay, now you use whichever tool, be it BDCA, the mic, Lean, whatever it is. Now you are measuring your performance and you want to improve it. So here they're giving you some action plans that you can use for improvement. So the actions may occur in several forms. So sometimes you see common action plans for quality improvement is that, for example, education and training of staff. This is an example of some of the improvements. Education and reporting of the finding to the outside vendor or public. Sometimes if you find, for example, equipment issues or product issues, then you have to report them saying that this is not a safe thing to be used. Development of policies and procedure is a common example for some of the improvement action plans that is developed. Changes in the organization or departmental policies. So review the policy based on a problem that had happened maybe sometimes. change in practice pattern, so you change the way you practice in the organization as an improvement process. And here they're talking about when you have a system versus knowledge-related problems. How would you know if you have a system problems or knowledge-related problems? How can you know?
We need to assess, Zahra.
Yes.
Knowing and not doing that system.
Knowing what?
Knowing but not doing.
Mm-hmm.
This is not a knowledge deficit.
Okay. It's not also a system deficit. This is intentional.
Compliance.
Yeah. So system problems. Okay, who can tell me what are the system problems that can impact the care or the quality of the services?
Non-availability of resources.
Resources and availability, staffing shortages,
protocols
or policies,
lack of
availability of equipment,
privileges
not being available. Yes. And then the knowledge will be anything that has to do with, the staff not being aware or not being knowledgeable about things. So when you have a system problem, here they're giving you examples of actions that can be reviewed, like change the communication channel. Sometimes if the communication only goes to one person and you depend, for example, on a hierarchical way of communication, maybe sometimes you have to change the way you communicate a certain message and you bypass the bottleneck or the reasons why the communication, for example, is not reaching to the right people. Sometimes they talk about using of a consultant service. Consultant service, the aim is that, first of all, this person is knowledgeable in that specific area of practice and they can advise you and guide you. Changing organizational structure can address system-wide problems sometimes. Changing organizational processes. So the way you you care for patients, the way you prioritize their activities. So looking at each of the process. So for example, lean management is an example of changing organizational process where you reduce or eliminate waste. Establish new positions sometimes, depends. So for example, starting creating the VAST or creating the UCT, all of those things are examples of establishing new positions. Changing inventory, so maybe the items that you have now are not appropriate for the care you're providing and it's time to change them. Revising job descriptions is also an example. Reallocating resources amongst the service areas. Adding or revising policies and procedures. Altering or purchasing or repair equipment and then changing forms. These are overall system-related solutions. If it is knowledge related, then you focus then on modifying orientation, providing service education, providing continuing education, circulating the written policies, again, making sure people are aware, providing references, sources, developing competency programs, or review the current competency program to ensure that people have the right knowledge required for that specific problem to be resolved. So these are generic examples of action plans you can use to address knowledge or system-related problems. To be very honest, I don't remember ever seeing any questions specifically on these points. Okay. The standard of care or clinical practice guidelines, they are also part of quality improvement examples. So the standard of care is optimal achievable level of performance, which is the type of care or services and outcome that the patient can expect from the healthcare encounter. And then we use clinical practice guidelines to actually reflect the standard of care that we want to be followed in a certain organization. So let me ask you a question. Do you think the clinical practice guidelines should be the same in all the hospitals?
No.
Why not?
It's based on the patient's populations Sometimes it's affected by internal process.
Okay.
And it's linked with the policies also, clinical
And-
practice guidelines.
And the availability of the resources.
Exactly. So clinical practice guidelines, one of the major thing in a clinical practice guideline, for example, I cannot expect that a hospital that has robotic surgery will have similar clinical practice guidelines for a hospital that doesn't, because your practice depends on the resources that you have and on the the type of evidence you're using. Also, the clinical practice guidelines are usually based on evidence that's available and published. So, for example, I could decide to go with the nice guidelines on a certain topic. Somebody might decide to go with the CDC guidelines. Somebody might decide to go with the American College, guidelines. So, the depends on what resources have you used. Depends on the evidences available to you, and it also depends on the resources of care that's available to your organization. So clinical practice guidelines are systematically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. CPGs are usually disease specific, so you'll find clinical practice guidelines for asthma, clinical practice guidelines for venous thromboembolism. You will find clinical practice guidelines for a certain infectious disease that you need to manage or monitor, because it's really details the care of the patient and the different decisions the physicians can take or the clinical team can take in caring for those patients. Evidence-based medicine is the objective and explicit use of current best evidence in making decisions for the care of the patient. In the physician standard of practice, they're now best known as the clinical practice guidelines. We talked about it. We have also what's called the clinical algorithm. What's the difference between clinical practice guidelines and clinical algorithms?
Is it the same of
The
clinical?
clinical algorithm is more like a clinical pathway, diagrammatical
The diagram,
representation.
exactly. Yeah. So the clinical algorithm is a diagram. Like usually, if you look at the AHA guidelines for the CPR, you will find that it is documented in a text, and then you have the algorithm showing you start with this, assess, is there pulse, is there breathing? If there's pulse and no breathing, you do something different. If there is no breathing and no pulse, you do something different. So it's the diagram that is drawn to reflect your level of care. Yeah.
Is it the same of clinical pathway?
It could be.
Because whenever I'm reading, I got a clinical pathway. This is the first time I'm looking to clinical algorithm.
Yeah, algorithm is, so for example, if you think about the CPR specifically, for example, it's not a pathway as such. The pathway really addresses the patient journey from beginning to end. So for your diagnosis, you do XYZ. For your investigations and collection of information, you look at 1, 2, 3. For the first day, the patient is supposed to do 1, 2, 3. For the second day, pathway looks at a journey mostly. An algorithm is step-by-step decisions. Like as we said, for example, for the life support, you find the patient is collapsed. You want to make sure, is there first of all, are they awake? Can they be awoken or not? So you have to tap on their shoulders, call them, are you awake? Are you awake? If they can be awakened, then that's different. You don't need to start CPR. If they cannot be awakened and they're not responding to you, then you have to assess for pulse, the pulse and the breathing. And when you do that, based on it, you decide there's a pulse, but the patient is not breathing. I'll focus on the airway management. So it is just at every step you have a decision. Is there a pulse? Yes, no. Okay, next. Is there 1, 2, 3? Yes, no. And you always keep moving from one step to another with a decision tree that is very clear to your care. The pathways mainly talks about, as we say, the full journey of, but both are used in a diagram concept. So that's where they look alike.
So Zara, clinical algorithm is more specific and focused.
More specific, yes,
pathway.
and with a lot of decisions. So you will always see those triangle, and it will tell you yes, no. What do you do next?
So you cannot deviate from that, but from the pathways.
Pathways are linked to the guidelines. Again, it will also have some decision tree, but it is it's more linked to the full journey of the patient and not a specific element of their care. Pathways and clinical practice guidelines are not set in stone. The physician can decide to act differently than what the clinical practice guidelines says, but they should have a justification why they did not use. But for example, for the CPR, you cannot deviate from the algorithm that was already set. You have to follow it ABCD, and your compliance is monitored based on those elements. Okay. Continuing with the clinical practice guidelines, they are generally produced by medical associations, relevant professional societies, public or private organizations, and they are approved by national professional groups, provide clinical rationale for clinical pathways and performance. Now, CPGs, for example, we have clinical practice guidelines for asthma management that's international. And then the Department of Health, for example, came up and picked or looked at certain clinical practice guidelines and developed it based on the UAE population and the UAE resources. Remember, we said clinical practice guidelines are very well or very much impacted by the resources available in a certain place. And then these were approved at the level of the Abu Dhabi, for example, government. And then you move from that into the hospital specific one, because then in some hospitals you have more advanced equipment and resources, and in some you have less advanced. So also your clinical practice guidelines should be based on your specific organizational needs or resources that you have. This is usually just a content or a clinical practice guidelines form or template. Definition, objective, criteria, content for the CPG, algorithms, involvement of the healthcare providers, assessment and reassessment, the role of the patients, indicators, which is how would you select or how would you assess the clinical practice guidelines success, references, and then the review period. This is very general, and again, every organization decides how they want their clinical practice guidelines. Clinical pathways, this is your answer, Riham. It's an agreed upon treatment plan. So it's a clinical pathway is multidisciplinary tool describing routine intervention for a group of patients with similar needs. It focuses on the patient and includes expected outcome of each step. And it's used to describe and implement clinical standard. They help provide quality and efficient patient care. Clinical or critical pathways are designed to include clinical performance criteria for the specific time period or intervals. In some organization, for example, you will have a clinical pathway for your for a patient with MI, and it will have very specific deliverables and achievements by time. You can say day one, for example, the patient will be on resting, starting day 2, based on these parameters. You would expect ambulation of patients. Or, for example, my mother went through a knee replacement surgery. What they had is, as soon as the surgery was done, immediately post-op, before he even goes to the unit, an X-ray was done. After the X-ray was done, she was taken to the unit. Few hours later, we had, so this was part of their clinical pathways. You have then the physiotherapy coming to assess your ability to ambulate within the same day, because their aim is to ambulate in day 0. And then based on the patient condition, they said, okay, today you start walking. Tomorrow you're expected to walk these many feet. The day after you're expected to walk these many feet and then be discharged. So it is clearly describes the patient journey and all the treatment plan elements in it. Any questions? So these parts I'm talking about, or these slides I'm talking about, is really focusing on the type of some of the actions that organizations take when they are improving practices in their services or in their units. The nursing standard of practice, this is the American Nurses Association developed it a long time ago. This talks about the nursing process: assessment, diagnosis, outcome, identification, planning, implementation, and evaluation. Where do we see this usually in the hospital?
Care plan.
The care plan. These are the elements of our care plan that we always look at, that we assess, we diagnose, we define what outcomes. The patient should be pain-free by this much. The patient should ambulate by this. The patient should achieve this, level of spirometry in 3 days, for example. So this is the nursing standard of practice. Then policies and procedures. This is just talking about the templates of policies and procedure. That's why no matter where you go, you find that there are certain elements you will see in every policy document. So things like definition, policy, procedure, a code or a number, policy statement, policy procedures, indicators, references, and the review period. What's the meaning of obsolete policies? What's an obsolete policy?
Which is no more required. Should be eliminated.
It's no more required. It's no more valid. So we don't use it anymore for whatever reason. And what's the retention of policies?
Those points which are still kept, which are valid.
Retention of policy talks about how long, like as per the policies and so on, you will have defined period in which you should retain the policies, especially policies that have been obsolete. So the policies will tell you that, for example, any policy will be available in XYZ location for the purpose of retention if required later on. And again, sometimes policies are required when it is, let's say there is a court event of something that happened, 10 years ago or 4 years ago when SSMC was opened. We treated a patient, and then somebody is going to come and complain, after a couple of years. So you should retain your policies long enough, again, as per the regulation and the stipulation of the country, to be able to, for example, present those evidences or present those policies if required during times of, and the legal norms actually define how long a certain document should be retained and retrievable in an organization. Okay, this is for policies. Okay, quality performance reviews. So quality and performance reviews. Here, depending on the type of the organization, the license and the accreditation standards, there are various internal or external demands for data and information that requires to be collected and presented. Much of the review activities, and we will talk about what they are required. If not for the accreditation or regulatory body, it's for the organizational survival in healthcare. And organization reviews or quality reviews are done to initiate improvement. What do we mean by those reviews? These are the kind of reviews that this is addressing. So, for example, Sentinel event review. For Sentinel event, do we do it voluntarily, or we are required to report them?
They are mandated.
They are mandated. So by the GOH is mandating us to report Sentinel events to them, and there is even specific time frames within which the initial report should be made. The preliminary report should be submitted within 24 hours, and then action plans and detailed investigation within a certain time frame, and so on. Peer review. When do we use peer review, for example?
To validate sometimes. During Sentinel events, we could do our peer review.
Yes, part of the Sentinel events could be a peer review, yes. When else? When do we use
part
it?
Of root cause analysis.
Part of root cause analysis, yeah, could be, because you need a peer who understands the process. Root cause analysis, I'm trying to think, because root cause analysis is usually when you keep asking the question why, or you try to create your fishbone with, you look at process elements, you look at people related elements. There could be a very small part of peer review in it. When else it's used?
When a staff underperforming or
When somebody is underperforming, which usually, it's usually brought up then by either a patient's complaint or by an event review. Complaints is one of the major sources or usages for peer review processes. It's also for when patients report and for example underperformance or under level of care, unacceptable level of care, peer review is usually utilized. Okay, and then medical record reviews. When do we use medical record reviews?
For quality improvement projects, we can utilize medical record reviews.
Yes, for quality improvement projects, true. What else? Anyone is aware of a regular medical record review that's done?
mortality review?
For audits and JCI.
Yeah, for JCI mandates us to have a medical record review that is the file review, somebody said, which is like done in collaboration with in coordination by the medical report team and committee. Okay, so in the medical record review process, you have a set standard or set elements that you look at. So you would look at your admission, you will look at whether the admission was done within 24/7 hours, within 24 hours of admission, for example, or of seeing the patient in ED, stuff like that. So there is clear criteria for the peer review or for the file review, medical record review, that you look at. Going back to the medical record review, which aspect of care is it? Is it measurable, appreciative, or perceptive?
Measurable.
Measurable. Medical record review. What about the peer review?
Perspective.
Yeah. Appreciable. The other one, appreciable.
Appreciative. Yes. Remember, we said peer review is when you need some person with the same level of the knowledge and expertise to evaluate the quality of your care. Like you cannot give a peer review, for example, of neurosurgeon and give it to the cardiologist, for example. They can never review each other's work because they are not having similar experience or similar work, for example, or similar events that they deal with. So it requires somebody to have an appreciation for the type of work that you're doing and the medical expertise. Okay. Blood utilization review. So what's blood? Anybody knows what's that? There is blood utilization and then there is drug.
Yeah, there is KPIs related to blood utilization after surgeries within 72 hours or within 7 days, like that.
Yep. So blood utilization here, it's looking at the blood bank and the packed RBC, the FFPs, and so on, the utilization percentage. Because what happens sometimes, the patient is going into the OR. The physician will do a cross match and order blood to be reserved for that patient without actually the patient needing it or without having a high risk of bleeding for that specific procedure. So what happens, they'll bring the blood, they will keep it ready for this patient, and then they will not use it. So that's a wasted blood units, for example. So this is, they review this, and the blood bank has a very clear KPIs on the utilization of blood units in the organization. Same thing for the post-operative within 72 hours and stuff like that. Drug utilization is the same thing. You look at the certain type of medications and how well you are utilizing it. One big example of that is the antibiotic stewardship, where you look at the antibiotics and how often it's being utilized. Is it needed? Is it not needed? And stuff like that. Surgical and procedural case review. This is a specific review of, could be a case review, a general case review, but specific to the surgery process. Code blue review, and we do this where we review each code event that happened in the organization and all the compliance with the AHA guidelines, the availability of the first aid, how quick that code team reviewed. All of that is part of the code blue review process. And then here you have the different, so these are examples of reviews, and here it is different intervals within which the reviews can happen. So prospective review, prospective is like concurrent. Can anyone give me an example of a prospective review? Concurrent means it's being reviewed while the care is happening.
Code blue drills?
Is
it
any medication error or something? Okay, or any incident which is happening, not the
incidents, and
current
all
one.
of those are actually retrospective. They have happened before, and now you're trying to find out. Prospective, the code drill is not one of the examples of the reviews, because here we're talking about care reviews, actual events reviews rather than drills and so on. But prospective review, for example, when we do the medical record review, sometimes we do open medical record review. So the patient is still inpatient, they're still receiving the care, and we go and we review their care while they are inpatient. That's an example of the concurrent review, for example. It's happening while the the patient is getting the service or the treatment in the organization.
What about the drill again? I did not get your concept there.
For what?
For the drill. I thought the drills is a concurrent review because they will be doing the practice while somebody is reviewing it.
What I meant, so the drill is not a review. A review is a review of care. A drill is not an actual patient care. It's something you're doing to be ready.
Okay.
If it's not a drill, Sahra, if it's not a drill, if it's really code blue.
Yeah. So
and then the debrief. Yeah.
Unless you are standing, usually when there is an actual code drill, or an actual code event happening. Okay, I'll give you an example. You know how now they have, for example, some stuff that they
CPR coach
evaluate the quality of the codes immediately, or the quality of the compressions.
Yeah, we have coach with the team.
What's that? What's it called?
The CPR coach is there with the team.
The coach, yes. So the coach is excellent. The coach, when you are doing the actual compressions and immediately it's telling you increase the depth, increase the speed of which you're or reduce the speed. That's a concurrent review. It's actually telling you about your care while you are providing it. So that's concurrent review. When we review the antibiotics of patients who are still in the hospital and receiving care, and we're reviewing whether they need those antibiotics or is it time to stop them and so on, or not, that's concurrent review. So it's happening while the care is being provided. The drill is the only thing I was objecting to, the word drill, because drill is not an event. But if it's the actual code review, yes. But there is also examples of code reviews that you do at the end. So, for example, the nurses, the team will do the code, they will document the code sheet, and then there will be a retrospective review. Yeah?
Yeah. Debriefing.
So, debriefing. And after the debriefing, remember, like we have the code blue committee, Prashuba and Kogi and the team. We collect all of the code documents on a monthly basis, and then we review them, because in that it has a lot of information. When did we start the code? When did we start advanced life support? When did we have the code team arriving? When did we? So that's retrospective. it's after the fact. It happened, and now I'm reviewing it. Focused review is a specific review on a certain element of care. So, for example, you might want to review only a specific segment of the patient care. You might want to review what could be a focused review. The antibiotic, for example, as we said, is a focused review, while you could have reviewed all of their medications, but you're only focusing on their antibiotic therapy usage, for example. So focused review is you look at a specific aspect of care and you review that. So these two are time bound. When you talk about retrospective or prospective, are related to which time was the review done. Focused is just relating on to which aspects of care have you reviewed. That's the only difference. Okay. Okay. When you do reviews, you definitely cannot review 100% of your cases unless it's required by certain laws or you have a very low volume. So 100% review may be necessary for low volume activities. So again, this is very old. To be very honest, I didn't see changes to this sampling technique by Joint Commission, and it's mostly used for data being collected specific for the Joint Commission review and statistics. And sometimes it's used as a reference guide for people who are trying to start collecting data for certain cases or for certain events within their organization that doesn't have a specific sampling. So it says 100% review may be necessary for low volume activity, which is less than 30 cases per quarter, or to establish a baseline for future sampling. And then here they say a sample of 30 if the population is between 30 to 100 cases, and a sample of 50 if the population is between 101 and 500 cases, and a sample of 70 if the population is more than 500 cases. Again, that was one of the recommendation of Joint Commission. Now, again, most of the data collections or samples actually have evidence-based tools that tells you which is the sampling technique that you should be using. But this is one example of the Joint Commission examples. So here was details of the different reviews and different activities used within the quality processes. And now we move into the risk management example. The goal of the risk management is in any organization is to promote patient safety and protect the organization from financial losses, which may arise as a result of risk to which it is exposed. So here we're not only talking about the risk management, the clinical risk management. You will see we're talking about more details about the risk management. A risk manager accomplishes this goal by applying the risk management process in the organization. So promote patient safety, protect the organization from financial losses. There's two. The basic steps of the risk management include these 5 steps: identify exposure to accidental loss, examining risk management technique that can be applied, selecting the best risk management technique for the situation, implementing the technique, and then monitoring the effectiveness of the chosen technique. And we will talk about it more. Okay, anybody knows what are the risk management techniques that can be applied to certain risks that were identified?
Techniques is scoring, no? This is prioritization matrix you are using.
Say that again, is that?
5x5 matrix, proactive and reactive, or?
No, the proactive and reactive, these are the different types of risks. We'll talk about them. But what are the risk management techniques that can be applied? So let's say you have
identification.
Identifying
the risk is the
identification is the first step, right? I'm talking about the second step.
Yeah. Then risk estimation and analyze and the
I'm
evaluation.
talking here. It says identify the risk, examine the various risk management technique that can be applied. So let's say you identified a risk of fire in a certain place. What would you do about it then? After you scored it, you analyzed it, you looked at it. What is the best risk management technique for it? Is my question not clear?
To fix that risk or?
Yes, to address the risk. What are the different risk management techniques that you can use?
You mean the tools like FEMA?
Risk assessment
failure mode analysis?
No.
Tools
failure mode is a different, it's an example of risk management. It's one of the risk management techniques that's to be used. But what are the risk management techniques? If you identify a risk,
is it the risk assessment tool, Zahra?
Say that again. The risk assessment tool?
Ishikawa diagram will use.
No.
No.
Okay. Let's say now you identify a risk of fire in a unit. What could be the actions to take to reduce the risk? What can you do? Give me examples.
For example, we will call the expertise fire people or facility management and focus on the area where it is like which is affecting more, like fire where it is affecting, which factor is affecting.
Okay,
is it
so
because
you look
of
at factors and then what would
eliminate the item that cause
fire extinguisher? Do we have? Is it because of staff lack of training? Is it because of?
So you look at your resources, and then you look at the training. Okay.
Value stream mapping. You mean the exact technique what we are using to assess?
You don't use value stream mapping or.
Yeah, you will not.
Eliminate the resource. Eliminate the thing which is causing.
Excellent. Now you're getting
fire,
there.
like
now you're getting there. So you have a risk. Okay, you've analyzed the risk, and now you have to do something about it. So either
like,
you eliminate. Excellent. You use the right word. Eliminate is one example. What else? What else can you do? If you can eliminate the risk. So, for example, okay, let's talk about it. We're talking about the risk of fire, right? One example, for example,
prevention.
in the yes,
and then eliminate.
Okay, sorry. I think my internet is breaking up. Can you hear me? Okay.
Now, yes, we can hear you. Do you mean whether we need to either prevent, accept, or eliminate?
Exactly. These are the risk management techniques. Yeah.
Yeah. Avoid and retention. Yeah.
So, for example, if we are in a hospital, can we fully eliminate the risk of fire? No, because we have oxygen, we have heat, we have all the elements of that increases the risk of fire. So we cannot eliminate. Can we accept the risk and say, what do we do? قدر الله ما شاء فعل. Can we?
Right.
Can we accept the risk of fire?
No. No. Periodic risk.
Periodic
assessment.
Prevention. Yes. So prevention is where we talked about. You bring in the experts. You review the prevention or the risk, the possible reasons for the risks. You implement, safety guards. You try to prevent it as much as possible. You make sure that there is no heat source next to the oxygen sources. You prevent smoking in the hospital. All of these are elements of prevention. And then what else? What was the next, Riham? Do you have them?
Eliminate, prevent, accept. There is monitor, but that
retention. Retention also.
Retain. Retain is more like accept. Prevent, eliminate. There is that risk transfer.
Acceptance.
There is acceptance. We talked about acceptance, and there is the risk transfer. The risk transfer means usually the main common way for a risk transfer is that, for example, you get an insurance, for example, on something, and then that insurance company will deal with the consequences of doing a risk transfer. Or let's say sometimes you cannot do something in your organization and you will ask another organization to take care of it for you. You don't have a cath lab, so you will transfer those patients to another organization just for the procedures, and then they come back to you. So we will look at it more, but I just wanted all of you to know, when we talk about risk management techniques, this is what we mean, is that you look at the different ways in which you can address the risk. You can accept certain risks, you can eliminate certain risks, you can transfer the risks, or you can prevent the risk from happening. Okay. The risk manager responsibility. The risk manager is the person in charge of the risk identification, evaluation, and application of the risk management technique, which includes shifting the risk or transferring the risk. Duties vary widely, but most often require the risk manager to perform basic risk management function. The risk manager role includes intervening with patient and family, along with implementing measures, new process or process steps to prevent recurrence of a certain risk. The basic risk management function include maintenance and monitoring of effective incident reporting. And incident reporting is the reactive risk management part, which the incident already happened. In some places, the risk manager is the one also responsible for claims management. And here we're talking about claims like the legal claims and court cases that are raised as part of the risk manager responsibilities. And then clinical and administrative responsibilities, such as policy review, credentialing, contract review, internal and external reporting and education, collaboration with the organization safety officers. So the risk manager might be the safety officer also in a small organization. So this is talking about staff safety, occupational health and safety, and so on. Collaboration with the financial office staff regarding insurance and other methods of risk financing, regulatory compliance, and then also establishing the risk management plan. And the risk management plan is a mandatory document in any JCI accredited organization. You should have a quality management plan, and then you should also have a detailed documented risk management plan. So this is talking about the responsibilities or the functions of the risk management. The risk management plan, as we said, sometimes is combined with the quality management plan, but they are two different processes. And here are just, again, like we talked about the quality management plan and we said what are the components. These also are the components of a risk management plan: purpose, board statement for the risk management, scope, authority, confidentiality, data collection, integration with quality management, and program effectiveness review. This is just template related requirements. The source of data for the risk management: documentation reviews and audits, peer review, morbidity, mortality committees and reviews, incident reports, infection control data, self-assessment, where this is what they do when they go to the units and they visit them and they discuss with them what could be the risk in their units. That's considered part of self-assessment. Proactive approaches to risk management, and we will talk about it. Somebody mentioned the FMEA is one of the proactive approaches. And then key performance indicators and data does help with finding some information related to the risk management. Complaints are part of the risk management informations and others as well. So it could be claims, it could be, reputational challenges and stuff like that. That could also be part of the risk management data. Here in the risk management, they talk about the aspect of the professional liability. And this is where healthcare organizations are legally responsible for the actions of their agents, employees, or officers. So if, for example, if a physician in SSMC does a mistake, then SSMC is professionally liable for their actions and the outcome of care that they have implemented or their employees have implemented. Corporate liability holds the employer legally liable for the wrongful acts of their employees. And that's why the organizations usually set policies and guidelines on fraud, misconduct, the code of conduct and practice in the organization to prevent those wrongful acts or to define what could be a wrongful act. These are examples. Now I will go through a couple of slides that talk about the liabilities for physician, nurses, and others. So the physician's professional liability includes things like liability of lack of documentation of treatment. So this is considered a liability. Inadequate workup or diagnosis being done based on the accepted standard. So they will look at the current accepted standard and you will evaluate whether the physician has actually ordered the right workups for a certain disease condition or not. The acts of others, for a physician or a consultant, the act of others like the juniors, their resident, intern, or trainee that's working with them is considered against the most responsible or the supervising physician. That's why it's very important that even to monitor and to countersign their documentation and to clearly and have a focus or pay attention to what they are doing. Failure to attend or follow up, so failure to attend and follow up with the patients on their care. Mistaken identity along with the institution, I'm not sure what does this mean. And then misdiagnosis, if based on inadequate examination or testing, is part of the physician professional liability. Mistaken identity. Wrong diagnosis followed by improper treatment causing injury is also a liability. Treatment outside the field of competence is a liability. And that's why they have to be privileged for whichever care they will provide. Negligence or failure to follow up after an acute stage of illness or the unilateral termination of physician-patient relationship. Sometimes do you see a situation where the physician will say, "Khalas, I don't have anything to do with this patient, I will stop the care." So the unilateral, where it's only one person's decision without explaining it to the patient, termination of the patient-physician relationship without informing the patient is a liability. Failure to obtain informed consent is also a liability on the physician. Failure to seek consultation or refer them to the right specialty. Use of unprecedented procedures unless approved by a respectable minority of medical opinions. What could be unprecedented procedures? That can be a liability. Anyone can guess?
The announcement of brain death?
No. This is talking about unprecedented procedure. So a procedure that never happened before in the medical
Maybe
field.
the procedure not listed in the hospital approved procedures. Like
not only the hospital,
if a dermatologist will do some procedure.
Yeah, not only the doing a procedure that you are not, that actually falls in the treatment outside the field of competence. If I'm doing a procedure that is not within my field. But unprecedented procedures is procedure that has never happened. Like this physician that wanted to do a body transplant, or was it a head transplant? I don't know which part was being transplanted. This is considered, for example, an unprecedented procedure. Yeah. So if you try to do that without having the proper justification within the, the umbrella of the organization, medical care, that's considered one of the liabilities. Failure to order
Even the
diagnostic.
drugs.
Even
The
the
drugs which is not, yeah.
If you use things that are not approved, are not as per the organization policy. Failure to order diagnostic tests which are considered to be a matter of common knowledge. Failure to obtain results of diagnostic test order. Infections resulting from failure to utilize proper procedure or precautions. Premature dismissal or discharge. Yeah. All of these were physician-related professional liabilities. And these actually, if a patient complains and these were found as the reason for the poor outcome of care, then physician can and the organization can be in trouble and might have to compensate the patient for their care. Example of professional liability for the nurses is administration of drugs that are inconsistent with the Nurse Practice Act or institutional policies. Failure to follow the physician orders. Failure to report significant changes in the patient condition. Failure to take correct or verbal telephone orders. Operating room sponge instrument miscounts. Patient burns, patient falls. Failure to report effective equipment. Failure to report established nursing procedure, to follow established nursing procedures. So these are examples of professional liability that might be on the nurse's level. The concept of negligence, this comes sometimes in the exam. It's the lack of proper care. The word negligence is the lack of proper care. And what is proper care? Proper care is based on the defined standards established by the law to protect others against harm. Proper care is judged by peers. If we're talking about medical malpractice, the concept of proper care is judged by the peers of that person. Remember, we said sometimes, especially in the medical malpractice organizations, you focus on the when you talk about proper care, you focus on who can judge, or the appreciative aspect of quality, where you need somebody with the same background, with the same level of experience to appreciate the level of care they provided. Reasonable care means there is both a rationale for doing or not doing something, and the rationale is the basis for decision making.
Sahra, maybe this we can replace it by evidence-based medicine or practice, because proper for me is different from others, or exactly. Proper care. So yeah. I think the best is even to review this and to be replaced by evidence-based medicine or evidence-based care.
Yeah. So when they say it's based on a defined standard of care, but then sometimes because even within evidence-based and even within clinical practice guidelines that are established, there are specific elements of the patient condition that might impact the judging of the physician or the reason why they are implementing a certain care. So it would be, even if you look at the CPGs or if you look at evidence practice, they always link it to the patient situation. So that's why you always need somebody, a peer, to judge in this situation with this specific patient condition and with these specific occurrences, was this the right care to be delivered or not? Where the science does not give you a clear answer, yes or no. So that's why you always have to have some elements of peer review in the care for patients. Is that okay?
Yeah.
Yeah.
Okay. And then the concept of negligence. What is negligence conduct or negligence in care? It says is doing what a reasonable person would not do is negligence, and failure to do what a reasonable person would do is also examples of a negligence. So not doing what you should do or what you ideally are expected to do, or doing what you shouldn't do is example of negligent care. Gross negligence is failure to act if there is a known or suspected risk resulting in adverse impact or death. So this is considered gross negligence. If I can see that there is clear evidence that the patient might end up having an adverse impact or death, and I don't act on it, then that's considered gross negligence. ما أعرف إذا في حد يعرف يقرأ فرنسي. المهم Ribsa Liquiture allows patient to prove her or his case without the necessity of an expert, especially when they fail to act on a specific example. And here, for example, is the surgical sponge instrument lift. This is very clear negligence, whether the that does not require any lawyer or any expert to review the care. Okay, this is just in more details about it. And you can see here when we talk about risk management, because this is the CPHQ following the American model, they have a lot of legal elements that are even embedded within the risk management practice. Let's see. Okay. Next, it's talking about in the risk management, what's a sentinel event? A sentinel event is an unexpected occurrence involving death or serious physical or psychological injury or the risk thereof. Again, these definitions were updated by JSI and others. When we say the risk thereof is talking about any process variation for which its recurrence would carry a significant chance for a serious adverse outcome. Again, I'm not gonna, here is important. We talked about sentinel events before, and we say they are special causes. Sentinel events are special causes or random cause variation falling outside the normal control limits of the process of care. Remember when we talked about variations?
Yes.
So
outliers.
It's you can either call it a special cause, or you can, here they say it's a random cause that happens outside the normal control limit, which means it's an outlier. It's something that happens. It's very clear. You can pinpoint the reasons why it happened when it is a sentinel event, and it's very easy to identify and signal out. Intensive analysis. This is very important. The word intensive analysis must be performed in each case, whether the sentinel event occurs in the organization or is associated with the service provided by it. Intensive analysis may or may not reveal the need to actually modify particular processes if it's historically under control. The organization is expected to define sentinel event for its own purposes. Intensive analysis, remember when we say the sentinel event review and all the details analysis, the questionnaire that goes into it, the investigation, the detailed study, the fishbone diagrams, all the review of the different processes that might have caused the sentinel event. That's why they call it intensive analysis. Yeah, this is a good important word to remember. Examples of sentinel events: unanticipated death or major loss of function, patient suicide, infant abduction, rape, hemolytic transfusion reaction, surgery on the wrong body part, and so on. So, responding to sentinel event, the organization is expected to conduct immediate investigation, determine whether or not to self-report. So here in the US, they have a voluntary self-reporting to organizations like the JCI. For us, for example, it is mandatory that we report to DOH on a certain time frame. respond appropriately to all the defined sentinel events, prepare and root cause analysis, RCA, and action plan. The root cause analysis is a process for identifying the most basic or causal factors underlying the variations. The intensive or in-depth analysis of a problem event to learn the most basic reason. An event is an occurrence that is either deemed to be or result in a significant problem. Anyway, I will just detail the root cause analysis. When you do the process for root cause analysis is you start by cause and effect analysis. You conduct interviews. You determine the root causes. You continue to ask why 5 times. Develop or recommend actions, changes or actions. Develop an action plan for implementation of change, and then report the conclusion. And usually the root cause analysis is the major element in the review of the sentinel event. Cause and effect diagram is same as the fishbone diagram or the Ishikawa diagram, which is this one.
Your voice is breaking, Zahra.
Is it okay now?
Zahra?
Can you hear me now? Hello.
We can hear you on and off.
Yes. Let me see.
You try again.
Let's see.
Okay, how about now? I didn't move. I didn't do anything, so it's still breaking?
Yeah, but go back to the previous, Zahra.
It's exactly the same. I didn't do anything different. 1 second. Just give me a minute.
It's okay. Just go to the previous slide, please.
The previous slide?
Yeah.
This one?
Yeah.
Yeah, no, it's just start explaining the cause and effect diagram because it's part of your sentinel event review and your root cause analysis. You usually use a cause and effect diagram. So it's also called a fishbone diagram or an Ishikawa diagram. And I just went in here to show the fishbone diagram. This is how it looks like. So you have the effect in one side. This is the outcome that the arrow is pointing to. The effect, and then you have all the different causes that you can be looking at it under a certain category. So it says usually you pinpoint the problem or the variations in the desired outcome, and then you add 4 to 5 branches of the arrow. Sometimes you can use the 4 M's, like manpower, method, machine, and material. And sometimes you can actually use your own categorization of the major reasons. And then smaller arrows show the different branches and the different reasons for why an incident has happened. So, for example, missed deadline. Some of the thing is that the material, I don't know, this is not related to healthcare, it's just general. But you try to categorize them under certain elements and then you add the sub-points under them. So this is for the cause and effect diagram. And here it's talking about things that are directly related to the concept of the risk management and the sentinel events, the reactive and the proactive approaches of risk management. From there, we move on to the FMEA. It says it's a systematic method for identifying and preventing product and process problems before they even occur. So you try to identify the failure modes and fix them before they happen. It does not require complicated statistics. And if FMEA does take time and people and resources because it's really a team-based approach for implementation. The purpose of the FMEA is to prevent process and product problems before they happen. Okay. here is the steps of the FMEA. Select a process and form a team. Yes? Okay. In the FMEA, you will select a process and you form a team. So why did they start with selecting the process before you form your team? Can anyone tell me?
To identify the best people to be part of the team.
Yes. So it's important that FMEA, like FMEAs can be different, can be done in a lot of different ways. For example, at 1 year we looked at the medical record. I don't know if somebody can remind me. It was something about the medical record safety and security. So they looked at all the ways the medical records can be exposed to unintentionally exposed to others, confidential records, and how we can reduce the possibility of that kind of exposure. So what they did is they looked at that process, they formed a team that specifically knows about that process. So your HIM team, your nursing team, your physician, somebody from the clinic, somebody who represents the porters who transport those records, somebody. So they brought each and everyone that has something to do with that process as part of the team. When we were opening the radiation oncology unit in SSMC, what we did is we brought in the team of radiation oncology along with the risk management team, and they looked at what could go wrong in this because it's the first time ever we are offering the service. So FMEA is very specific to things that you've never done before or things that never had any problems before. So you select the process, you define the team that best works on it, then you diagram the process and the detailed processes underneath it. You have to really draw it very clearly and by taking input from everyone. Then you start brainstorming what are the potential failures. So what could go wrong? You look at each step of the way and what could go wrong, and then you list if they go wrong, what is the effect that they will all have. And then you prioritize the failure modes. I will show you now. There is a certain calculation for the risk priority number to be detected. You will look at how often this can happen. This specific incident can happen, how often it can happen, how easy it is to detect, and if it happens, what's the severity of the outcome will be. And based on it, you prioritize, or you have a score that's called the risk priority number for all the failure modes. And then you identify the root causes of the failures. You redesign the process to avoid or to clear out all these root causes. You analyze and test the new process, and then you implement and monitor the redesigned process. This is an example of the failure mode effect analysis. It's which process step it is. Under each process step, you could have multiple failure points, so you can see the failure points, and then if it fails, what is the potential effect, and then what's the severity. The severity is represented in a number. So for example, here it's from 1 to 10, and how severe is the effect on the customer if it happens. And then you look at the potential causes and how often they can happen. So what's the occurrence possibility for it? And then you look at the controls. Do you have a control? Will you be able to detect if these things happen? And you score the detectability of that process. And based on it, you have your risk priority number. So in this example, I know it's very small, but what would be the top item or the top element that you will work on it? From this?
The highest number.
The highest number. So for example, 196 is the highest number, and based on it, so you look maybe at the top 3 or so on, and based on it, you will start your activities or your action plan, and you will redesign the process. Okay. FMEA is clear?
Yes.
Can I ask Zahra what tools we use here for brainstorming?
For FMEA specifically?
Could be or in general.
In general, brainstorming is free. It is a tool on its own. Brainstorming itself is a tool where you ask people. I think we will talk about it in some of the following slides. It's just an open space where you ask people to give you ideas on a certain topic, and you just record the topic. The concept of the brainstorm that it should not be judgmental. It should and it should be like, for example, you will look at, let's say, for example, you will look at the radiation oncology. You will go in, and because you have a team that knows the process, you will start saying, okay, now the first process is the patient registration. What can go wrong? Oh, the computer can fail, the registration staff can be present. So they will tell you, people will just have the free flowing process to talk about what could be, and one person is going to be documenting the ideas that were brainstormed. So there isn't, the brainstorming itself is a tool. It's considered a tool, but there isn't any template for it, if that's what you're asking.
Yeah, thank you.
Yeah, okay. We've covered some of those, which is about the patient safety before. We said the Institute of Medicine that's released the report that's called "To Err is Human," and it defined patient safety as freedom from accidental injury caused by the medical care. We even talked about the word accidental injury, and we said sometimes medical care does require some injuries, like when we do surgeries or when we open up a patient or we give you medication that have some, the medications in itself can be harmful. So freedom from accidental injury is the aim of the patient safety. And medical errors are the unintentional preventable mistakes in the provision of care that have an actual or a potential adverse impact on the patient. We talked about safety culture. Again, we said it's the values, attitudes, perception, competencies, and the pattern of behaviors that determine the commitment to and the style of an organization health and safety management program, and that organizations with positive safety culture have mutual trust and shared perception of the importance of safety. And then they believe also in the efficacy, they have confidence in the efficacy and of their preventive measures. We talked about safety culture assessment before. I don't know why is it repeated here. And this is where we talked about surveys like the patient safety culture survey and stuff like that as a tool to diagnose how safe or how it's the safety culture in that organization. We talked about these as well, the different levels. We talked about the Russian patient safety goals. Okay. Now, we're talking about the concept of something called the utilization review. And this starts by defining three terminologies. One is the overutilization, which is excessive use of resources, underutilization of the lack of use for the available resources, and misutilization is the inefficiencies of sometimes overutilizing or underutilizing resources. And then here they're saying that the case management is part of the utilization management exercise. And utilization management should be done without compromising the quality of care. Okay, question to you. Can anyone give me an example of overutilization in healthcare? Anyone?
Documentation.
Utilization is something that you use, not burden, not a burden on you.
Consumables.
Like using general anesthesia for endoscopy instead of like conscious sedation. Because now we're using a lot of general anesthesia for endoscopy, although it's safe to use conscious sedation.
Okay, so using anesthesia is a general instead of a sedation or a local anesthesia in some cases. That's true. What else? Overutilization. Whenever we say overutilization, I'm thinking there is something that Riham should always think about.
Antibiotic, I was thinking, but is it not misuse?
No. So antibiotics, again, misutilization includes both. It's an inefficiencies, but the reason why we monitor antibiotic is because it's mostly overutilized. Right. We go over the counter. The physicians will order too many, like longer days for the antibiotics or the strong type of antibiotics, for example, for a simple. So it falls mostly under overutilization, but some of it is misutilization where you use the wrong type of antibiotic for the wrong type of infection. That's true. What else? Overutilization.
Gloves, gowns for the procedures.
The PPEs are usually sometimes over, sometimes under. When we need them to use, they are underutilized, and sometimes it's overutilized for unnecessary services. True. And then underutilization is when you have something that is available to you, but you're not using it the way you're supposed to use. So sometimes, for example, you might have patients who require a higher level of care to be in HDU or in ICU, but they're actually kept in the unit. So this is sometimes considered underutilization of the services. Or sometimes you have, what could be underutilized? You might have a certain medication or a certain tool that might be underutilized. For example, I remember initially when the PBID project was started, it was a bit underutilized and that's why they were measuring how many of the staff are actually using the PBID device and the percentage of compliance and stuff like that till they have reached to the right level of utilization, for example, of that device. So think of anything
underutilization.
Yeah.
Underutilization in the book, when I was reading it, it's just referred to the mental health concept because it's existing, but most of people does not believe in it, so they may underutilize this service.
Could be, yeah. True, could be.
Like what we have here at SSMC, the surgical procedure room. The physician prefers to use the OT room instead of procedure room, although the procedure room is fit enough to use for certain procedures.
True. So that's an underutilized service, even though it's available, and evidence is necessary. The evidence is available that it can be used, but they don't. That's true. And then misutilization, as we said, is inefficiency. Sometimes you use something for the wrong purpose. For example, using the wrong antibiotics for the wrong indication, for example. Sometimes we talk about, using sterile equipment to give birth to patients, sterile gauzes, for example, to give birth to patients. So think of any inefficient or unexcused use of the resources in the organization as misutilization.
Like admitting inpatient instead of daycare.
Yes, admitting inpatient, or the day surgery where you can utilize day surgery services and patient will leave while the physician might be admitting them to the hospital for that procedure. Yep. And case management that deals with the length of stay, patient days and stuff like that is also considered part of the utilization. Actually, all of the concept of the length of stay is focusing on the utilization, because as an organization, we're supposed to be utilized for the patients who really require the service instead of utilizing the resources for patients who are overstaying their level of care. Here is talking about the case management. It's about the process of monitoring the care of managing certain diseases following an agreed upon treatment plan. So the treatment plan is usually established by the physician in cooperation with the primary care provider, patient, and family. It has clearly defined and measured goals and expected outcomes. A plan and a tool for patient and family education should be available. There's a system of communication between healthcare providers, the payers for the information, and then there's a discharge planning that begins at the start of care and is developed by a combined effort of the healthcare provider, physician, patient, and family. So this is just talking about the concept of case management. It includes an intake and an assessment process, development of care plan, implementation and evaluation, case coordination and referral, discharge planning, and then some elements of quality management, especially in data collection. The members of the care team for each case can include the patient, the assigned nurse, case manager, physician, specialist, other healthcare professionals, and then the patient family member as well. Discharge planning is an element of the case management. It should start at the first day of admission, included in the initial assessment, includes social and economical factors, and then patient education is a critical part of the discharge planning, and patients are discharged early but appropriately in coordination with community resources. And that's why from the admission, you have your discharge planning or discharge assessment tool coming up for filling by the staff. The plan is implemented through combined effort of the team, should be re-evaluated. All of this is part of the case management responsibilities. There isn't much here. I don't think we'll be able to finish. So disease management here refers to the management of chronic diseases. It's different than case management. Case management is case by case in the hospital. Disease management talks about chronic diseases and how you manage them as a team. So the diseases are selected on the basis of how chronic they are, their cost, the patient volume, the treatment of by both primary and specialist physician, wide variance in the practice patterns, and significant potential for patient involvement. Disease management usually happens at the level, not only at the hospitals, but even at the level of national health services. Like, for example, if you see DOH gave us certain diseases that they look at. Anybody can remember what are those diseases they usually monitor by DOH?
From infection control, all communicable diseases.
All communicable diseases, excellent. What else? There are certain KPIs we always report on.
Stroke, MI,
stroke, MI, heart failure, asthma, pneumonia. So there are certain diseases that, asthma specifically for children, that they look at and they decide to implement the concept of disease management on it. And that's why you even have the clinical practice guidelines and pathways defined by even DOH for those patient population. It includes patient and family education. It also includes outpatient drug management, requires physician buy-in and support, some triaging protocols, as well as risk assessment tools for the primary, secondary, and tertiary prevention. Other programs integrated with the quality management. So you can see infection control is also mentioned and talks about the leadership of the program, surveillance, identification, isolation, patterns and trends monitoring, guidelines, policies and procedures, education and training, and so on. And they even consider infection control linked with the concepts of utilization management and risk management. All three of them should be linked, and the information amongst them should be shared, and they all should be part of the quality improvement processes in the organization. Let me see very quickly. Okay. Do we continue? We've got these couple financial management slides to cover. Do you want me to continue or do we stop? Hello, everyone.
It's up to you because it's 11 and 8.
Okay, your voice is breaking up. I don't know why my internet is acting up right now.
We know that you have another commitment.
Maybe next week,
Another
Sahra.
topic, I think.
That's all right. I just want to cover this. Okay, tell you what, I'll just go to the questionnaire, and then next time just remind me to go back to the financial management elements. Now, okay. Here it's saying a quality professional in a home health agency is charged to develop a quality management or a quality improvement strategy. Of the following options, what is the first step? Develop strategic quality initiative, determine roles and responsibilities of the leaders, draft the quality management QI plan for review by leaders, or define the scope of care and services. You have the answers?
Is it D?
D.
I heard B
D.
and D.
D. Define the
Daddy.
scope of care and service.
I don't really remember.
It always starts with define.
It always starts with define. Okay, let's all look. I don't know. This was the answer. I was looking because it both has leaders in it. So again, as we said, always everything starts by the leadership. But then I was confused between B and C, to be very honest. I'll have to search for this and look for the reason. Why did we select drafting the QM or the QI plan for review before the roles and responsibilities? Okay. Okay, the main objective of implementing a case management program in healthcare organization is to promote the principle of quality management, total quality management, risk management, utilization management.
Total quality management. No, sorry, risk management. Case management program in the healthcare organization.
Total quality management.
Total quality.
D, utilization management.
Utilization management.
Because of case management?
Case management.
Yeah. This was the last part we did, so it is
utilization management.
It is utilization management. And it was actually in the slides. We go very quickly. The first thing we say here, case management is part of the utilization management, even when we were talking about utilization review. And then when we talked about case management, we linked it also to utilization management. We talked about it as an example of the utilization management practices. Yeah. Okay. Why should a UM is utilization management? Why should a utilization management plan include a conflict of interest statement? We didn't say it in the course, but based on your understanding of the utilization management, why should it include a conflict of interest?
Okay.
So guys, I'm not sure if it's breaking up from my side, but what are the answers?
C.
P, to prevent economic credentialing. Okay, sorry. Can you put it in the chat? For some reason, I'm not able to hear all.
It should be B.
So somebody said B. What are the other options?
To prevent economic credentialing.
So you're all, how many of you are saying it's B?
C.
Can you raise your hands?
Actually, I'm between both B and C.
Okay, let's see. How many of you are saying is option B? Can you raise your hands? Option B?
أنا أشوف option A صراحة.
Okay, how many of you says option A? Let's go from the beginning. Option A. Selwa, you think it's option A? Can you raise your hand? So Vidya is A, Selwa is A.
Yes.
Riham said A. Okay, how many of you think it's Vidya? You can put your hand up. How many of you said it's B? Option B. Okay, how many of you are saying it's option C?
Me.
Okay, see, we have 3.
Me,
Vidya,
me,
you are A, B, or C?
I have doubt between A and C.
Okay, how many of you say it's D? Okay, so the concept of utilization management, as we said, it has to do with reviewing utilization, whether something is underutilized, overutilized. It deals with financial decisions also, and reports and so on. So a conflict of interest, regardless of utilization management, is actually to remove bias from any decision that you're taking. When you are reviewing when you are submitting your conflict of interest statement saying that I have no conflict, so you're not biased toward anything, you're not trying to increase something's utilization or to reduce something's utilization, you want to give an unbiased decision. So A is the answer. Yeah, economic credentialing means you give them some credentials, some qualifications in economic management of something, but it prevent economic credentialing that doesn't have much element, and then to provide for security and integrity of information does not really affect it because the information is provided by the people responsible for the utilization management, and then to provide immunity for physicians reviewers is also not related to this. Okay. This is one of the tricks where they give you a very big scenario. So Sunshine Community Medical Center had begun performing angioplasty procedure for cardiac patients in anticipation of providing cardiovascular surgery services. The administration then failed to negotiate a contract with the cardiac surgery team of physicians. The hospital and its cardiologist negotiated an exclusive contract with another hospital in the area to refer all cardiac patients needing angioplasty to that facility. This action constitutes risk retention, risk avoidance, risk shifting, or risk prevention.
C.
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 Shifting.
C. Risk shifting.
Okay. So the answer is C, risk shifting. So because doing angioplasty in the facility was risky, risk avoidance is not doing anything at all. Risk shifting is that you took it from you to somebody else's and you let them handle the consequences. Risk retention means you accept the risk, and risk prevention means you don't even do anything. Prevention and avoidance are basically the same point. Okay. Which of the following best supports risk prevention? Risk prevention: annual practitioner profiling, monthly event occurrence reporting, root cause analysis, failure mode, and effective analysis.
Failure mode.
Failure.
B.
D.
I heard B. I heard D.
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 Okay.
Because predictive.
FME.
FMEA, yes. So FMEA, as we
Most
said,
of the time, risk prevention, Zahra, is proactive. And
yes,
the failure mode and effect is also an proactive.
true. Okay. Because if you look at the others, all of them actually are reactive. Profiling is when you collect data on the performance, so that's reactive. Incident reporting is reactive. Root cause analysis is reactive. So all of it is reactive. Okay. Negligence means lack of proper care. In healthcare services, proper care is determined by JCI standards, jury of civilian peers, tort law, or medical peers.
A.
D.
A, B, C, D. Okay, I heard two answers. Who else?
I think B.
B? Okay, who else?
No, it's
What
by
is jury of civilian peers? What it means, civilian peers?
You tell me.
Civilian outsiders, no patients.
Outsiders. Yeah.
So the options now are A and B?
D.
No.
D?
D.
D, okay, there are two D.
We have already said it is based on standards and peer review.
Yeah, so in healthcare services, proper care is determined by. This was actually one of the examples.
Peer review.
Hamdan.
This
Yeah.
is medical peers.
D. Peer review.
Yeah.
Medical
Peer review.
Remember
Medical peers.
we said, and this is actually the question Hamdan asked, the proper care. Like he said, it should be clinical practice guidelines. And then we talked about sometimes there is variations in the even in the clinical care of the patient because of their condition, complication, unique patient needs, the resources availability, and all of that. So it's mostly determined by medical peers reviewing the care or the standards. It is related to cost. Okay, what's the most important relationship between structure, process, and outcome as a types of indicators of quality? Interdependence, structure directly affects both process and outcome. Causal, structure leads to process and process leads to outcome. Relational, useful for comparison but not causal. There is no relationship. They are categories used to group indicators. So I heard A.
Yeah.
Yeah, A. They're interdependent.
Yes.
B also can be. Casual.
You're going to make me cry.
No, it's interdependent.
A.
Interdependent. A.
B.
I kept singing it. I kept singing it, saying it's a causal. It's a causal.
Yeah, true. It leads to the outcome.
It's a cause and effect relationship between structure and not even structure as much as process and outcomes. Remember when we said if your outcomes are great, that means you don't have to worry about your process because it's only that good processes lead to good outcomes. So always remember the relationship between structure, process, and outcome is the cause and effect or causal relationship. Interdependent, yes, they are interdependent, but in a way that's a cause and effect relationship. Yeah. That's it. Okay, so next time, inshallah, we'll do the finance management.
Thank you, Zahra.